I am Doug Johnson. I'm the vice chair of the board for Dialysis Clinic Incorporated. I'm also a practicing internal medicine physician. It is fantastic to be here. Thank you to AAKP for the invitation. And thank you to Richard Knight and to Paul Conway, both for the invitation, but more importantly, for everything that you are doing to improve care for people with kidney disease. So I work for a company called Dialysis Clinic Incorporated. We are a nonprofit. We started in 1971. So my dad, Keith Johnson, started DCI 48 years ago, 2 years before Medicare covered dialysis, to open one dialysis clinic to save the lives of 8 patients. Somehow we've grown, not intentionally, but somehow we've grown. We currently care for 15,000 patients on dialysis, 3,000 patients with chronic kidney disease, 240 clinics across 28 states. On our outcomes have been evaluated and compared to other national providers, and we've had the lowest mortality and hospitalization rates for all of the years that they've compared us. We knew, though, that we should not only focus on dialysis care, and I think that's one of the biggest messages you've heard today. If we wait until someone is on dialysis, we've waited too long. So 5 years ago, we created an organization within DCI called Reach Kidney Care. We provide care currently to more than 3,000 patients with chronic kidney disease, 8 locations, 7 states. Our primary goal is to keep people off dialysis. So I work for a company called Dialysis Clinic Incorporated. My primary goal for DCI is to get ourselves out of the dialysis business one patient at a time. Thank you. We also participate in 6 different ESCOs, and ESCO is an accountable care organization for patients with kidney disease, and we've learned a great deal with that. We also run 3 organ procurement organizations under the name of DCI Donor Services. Because of the work of our staff in DCI Donor Services, 647 people received a kidney transplant in 2017, which we see as an incredible success. Okay, so here's my honest thoughts about where kidney care is today. I think it's broken. The financial incentive is to put people on dialysis. There's a financial disincentive for transplant, and there's no incentive to provide better care for people with chronic kidney disease and keep them off dialysis. We love working with Adam Bowler, the Deputy Administrator for CMMI. He has said no industry is good or bad. Providers will follow incentives. And the problem is that the incentives are to put as many people as possible on dialysis. If you look at people with chronic kidney disease, so how many people in the audience have kidney disease? The number one thing that I hear from people who I see in my clinic and also people who I've seen when I travel with kidney disease is, I wish I knew earlier that I had had kidney disease. Do you guys agree? So if you look nationwide for patients with less than 30% left of their kidney function, so they've already lost 70% of their kidney disease, less than half even know that they have kidney disease. If we look at the start of dialysis, more than 11% of people are starting dialysis with more than 15% of their kidney function, which is concerning for me because dialysis only provides about 10% of the kidney function, so I question why that many people are starting dialysis that early. To me, dialysis is the default. So if you had kidney disease and you had a choice between transplant and dialysis, how many of you would choose transplant? Richard, I know your answer. So the vast majority of us would choose transplant. The best therapy, the best renal replacement therapy, transplant, only 2.8% of people receive a transplant and avoid dialysis. That is a failed system. For people starting dialysis, almost a quarter of the people starting dialysis in 2016, the most recent year that we've looked at, almost a quarter of those patients were 75 years or older. And so my question is, for how many of those people was there a difficult discussion had with them and their family to let them know that for some individuals, if you have other medical problems, you'll live just as long if you don't start dialysis than if you start dialysis? Do you guys agree that the current system is broken? Yes, good. Thanks for clapping. I agree with you. So then the question is, what do you do? And I think for me, the number one thing that we have done is we've gone upstream to provide better care for people with chronic kidney disease, to make it less likely they need dialysis, and also if they do need dialysis, to push back that start. So our program is called Reach Kidney Care. To me, the most important component of our program is one-on-one, face-to-face education and care coordination with a nurse. The first meeting one of our patients would have with a nurse could last for an hour and a half long. And our primary goal as we talk to the individual with kidney disease is to find out from that person their life goals, because only when you know their life goals can you work with someone to make sure that their current therapy matches their life goals. We also strongly believe that as we develop this trusting relationship with the patient and their family, we then are able to see changes in care with the individual more engaged in their own care. In addition, we want to make sure that we go as far upstream as we can. We want to prioritize transplant. If a patient does need dialysis, we wait later and start when they are between 5 and 10% of their kidney function. But the most important thing for us is, in that first conversation, we tell them, you were 2/3 of the way to the dialysis clinic. We want to work with you to keep you off dialysis. And there are many things that you can do to either avoid dialysis or at least push back the start. And this is the red, highlighted in red, is the group of patients who we are currently managing. And so it's less than 30% of the kidney function. I would love to provide care to more individuals. What we're trying to do right now is first focus on those with the greatest need, and then as we hope to see success in those areas, we want to go further upstream. And so I think, describing the program can sound really good, but the real question is, what does it mean to the person? What does it mean to the individual who can be impacted, the individual who has chronic kidney disease? So this is my friend Scott Gongaware. He has vasculitis, and because of his vasculitis, he has chronic kidney disease. He's extremely active. He loves to hunt, he loves to fish, he loves to go hiking. And his fear is that if he were to start dialysis, his life as he knows it would end. So he did go to see one of our care coordinators in Western Pennsylvania. And after meeting with Terry, he sent her this note. And he said, "Terry, thanks for learning so much about me and my background before our meeting today. Thanks for getting to know me so that you could meet me at my intellect. Thanks for putting up with me. Thanks for having so much flexibility with the education. Thank you for your passion. Thanks for having the courage to answer sensitive questions. Thanks for the 80-20 pep talk. I took a step back after a couple of years, after a couple of flares, and after some recent infections. I have a lot of work to do. Thanks for being so open about things and for understanding my mindset. I appreciate your kindness, the time you spent with me, and your passionate desire to help me." And so I reached out to Scott after I'd seen the email that he sent to Terry, and I asked him if it was okay for me to share this when I talked about our program. And he texted back and said, "Yes, feel free." He also said, "I've spent many hours in professional care. DCI gave me more attention and adaptable education than I have ever had in that one visit." And so I think there is a real value of sitting down with a nurse. I will tell you also, as a physician, I will see my patient. I will then I'll send the person over to our CKD care coordinator in Middle Tennessee. And then I'll get this note for all the things that they covered in the meeting with the CKD care coordinator. And I'll be like, why didn't you want to tell me? What's wrong with me? I do think there's a different relationship. It's more of a peer-like relationship. And so there's a different level of support when you go to meet with a nurse and talk with a nurse. So this is Lynn Ashworth. She lives in Kansas City. This is actually Lynn with her wife, Catherine. Lynn is the shortest person on the picture. And she has been seen by the REACH program, our REACH program there. She's cared for by Jody, by Jody in Kansas City. So she originally had stage 3 chronic kidney disease because of hypertension, congestive heart failure. She then had a number of medical events, and she's progressed to stage 4 chronic kidney disease. So she's had many visits with her nephrologist. And it's really hard to see her numbers drop and to see how things are progressing. So she talked to us about what it's like to go see the REACH program after she's seen her doctor. And she said, "When I get to see my REACH team, I bring myself back to the center. It's like seeing a friend I haven't seen in a long time. My care coordinator takes the time to see me as a person outside of just being a kidney patient." And so I think both for Lynn and for Scott, they've had the opportunity to be cared for in a different way. I think many, Barry, you were talking about the current system. I think they've benefited because they've been able to receive care in a different way. So the stories are good. I think for me, I like knowing that we're focusing on this, but the real question is what type of an impact can we have? And so these are the results for our programs. We currently care for more than 3,000 patients, 8 locations in 7 states. This for me is early. I think we can do so much better than this, but I think it's encouraging to see our initial results. So number one, if you are over 70 years old and you have multiple medical problems, we know from published literature that you are likely to live just as long if you don't start dialysis than if you do. If we sit down and talk with you and you say, that's okay, I really want to start dialysis, I fully support that. I just want to make sure that each person who's starting dialysis is doing that with open eyes and that they've had the opportunity to have that difficult discussion. So if you look, I don't even know the national average for percent of people who choose not to start dialysis. I can't find it anywhere, but my bet is it's a very low number. So I'm guessing 2%. With our REACH program, 10% of the patients who we follow have decided not to start dialysis. And of those people who've decided not to start dialysis, very few actually change their mind when they get to the point that they need to start dialysis. Number two, if someone is starting dialysis, I would rather have them get a transplant than if someone needs renal replacement therapy, I'd rather have them have a transplant than start dialysis. Nationwide, we talked about this before, it's only 2.8%. Currently across our programs, it's 6.6%. In our program in Middle Tennessee, the preemptive transplant rate is 15%. We know we can do much better. Delay start by 6 months. We estimate that we can delay the start of dialysis by 6 months. Much better for the individual who has to receive dialysis care, also less expensive for the system. It's hard, you saw the different progressions of chronic kidney disease. It's hard to truly prove that that we are starting them later. So what we do is we kind of look at components, and we look at patients starting with a GFR greater than 15, between 5 and 10, and between 10 and 15, 5 and 10, and less than 5. And what we're seeing is that nationwide, 11.3% of patients start with more than 15% of their kidney function. Within our program in Spartanburg, South Carolina, our largest program, it's less than 5%. For patients starting between a GFR of 5 and 10 to 5 to 10%, nationwide it's 47%. Within our Spartanburg program, it's 70%. So we do think that we can safely push back the start. Now, if I start dialysis, I really don't want my first treatment to be in the hospital. I can get sick in the hospital. I can get infections. The sad part is nationwide, 2/3 of people who have their first dialysis treatment get that first dialysis treatment in the hospital. Within our program, 55% of patients are able to avoid hospitalization, which I think is a good thing. If I had to be on dialysis, I would rather dialyze at home because I can then do the things I want to do for my life and not be held back by going to the dialysis clinic 3 times a week. So nationwide, 10% of patients start at home. Within our program, it's 22.9%. We can do better, but at least that's an improvement. And then finally, to me, the worst part of someone starting dialysis in-center is that 80% start with a temporary catheter. If someone is starting with a catheter, they're more likely to have an infection, more likely to be in the hospital, more likely to die. So national average, only 20% are starting with a permanent access. Within our program, 51% are starting with a permanent access, which is really good. We can do better, but at least it's a good start. Most importantly for me, though, we share the transitions data because it's data that we have. Most importantly, though, I think as we're providing care for someone with chronic kidney disease, we should care for them with someone who currently has important clinical needs, not someone who may need dialysis in the future. And what's been very exciting for us, we do have one commercial partner. We have 2, but we have one that we've been working with for the last 3 years. And a couple months ago, they sat down with us and showed us the change in the cost of care for patients with stage 4 and 5 kidney disease, not on dialysis, after they entered our program. And I will tell you, I'm not allowed to share the numbers yet, unfortunately, but hopefully they'll let us share the numbers soon. But the numbers that we saw were better than we thought they would be. And so for me, it's very encouraging. We felt very confident that the program helps individuals. The hard part is if you keep providing it for free, it makes it difficult to do this long term and to have it available to as many people as we'd like to give the care to. And so it was really encouraging to be able to see how impactful it is also on the cost side. And so I'd like to end with my friend Bill Peckham. So Bill always talked about living the breadth of life. And he talked about making the most of every day. And so I think the most important thing for me as we're caring for individuals with chronic kidney disease is to do everything we can to make it as likely as possible that they can have the life they would have had but for their kidney disease. Bill was an amazing person. I don't know if many of you know Bill Peckham. So he was an amazing person. He was on dialysis for 27 years. Unfortunately, he passed away in January. And at his memorial a month later, his best friend Debbie gave out medallions, and I carry one in my pocket every day to remind myself that I need to do more. And on the back of the medallion, it says, "Live the life you were meant to live." And I agree with Bill 100%. Thank you.